Now, if you're dealing with these children who are having this problem, then you have to understand certain dynamics as well. If you see, this is a genovalgum and is usually in a child, but if you look closely, the right side appears little normal. The left side is more in valgus as compared to the right side. Now, whenever a child comes to you, once you have taken the detailed history and done the detailed clinical evaluation, you have to first ascertain whether is it a unilateral genovalgum or is it a bilateral genovalgum. Now, there could be certain differentials which may be related to the bilateral genovalgum. Bilateral genovalgum may include, most commonly it is always physiological. It could be related to dysplasias as well. For example, patient may have a spondyloepiphyseal dysplasia or certain other problems in which may be associated with bilateral genovalgum, or there may be renal osteodystrophy underlying. This could be one cause of having a patient may present with bilateral genovalgum. Now, if it's unilateral, it's only affecting the one knee and the other knee is in normal state, then there are other differentials which should come into your mind regarding unilateral genovalgum. One of the cause of the unilateral genovalgum could be trauma. You have to dig out the history. Was there any history of trauma? Was there any history of fall? Was there any history of surgery to this knee? Because the next could be the physeal damage during iatrogenic damage during the surgery, or it could be the physis abnormality, which could be in form of, which could be affecting the one side of the knee only, and this may be predisposing one knee to increase genovalgum. So whenever first ascertain whether it's unilateral or bilateral, and then make your differentials accordingly. For bilateral, it's always physiological, renal osteodystrophy, or skeletal dysplasias. But with unilateral, you have trauma and physeal damage, which you should be keeping in mind, and you should rule it out on history. Now, if you have this child which is appearing with bilateral genovalgum, what you do is, when a child of more than 10 years of age comes to you, you always measure intramallear distance. What is intramallear distance? That is from this medial malleus up to the medial malleus. You take a point between medial and lateral malleus and you mark it on this, and similarly on the right as well as on the left side, and you measure the distance from this point till this point. If this intramallear distance is more than 8 centimeter, this means this child has a bilateral genovalgum. Now, other way of ascertain whether it's one-sided, bilateral or unilateral is that you drop a plumb line. You ask the patient to hold the tip of the plumb line at the navel. You drop the plumb line right in the center. The point where it's touching the ground, that is actually your center point. From there, you measure it up on the right side as well as the left side. If you have a normal value on the one side and abnormal value on the other side, that is why usually it's very clearly visible straight away. But if it's slight difference, usually you have to ascertain it by measuring it from the plumb line center. Therefore, intramallear distance of more than 8 centimeter is mostly pathological, and usually if it is present after than 10 years of age, this is bilateral genovalgum, which is more likely to be pathological rather than physiological. And then we have to also assess, for example, if you see this, you cannot actually assess only the valgum. You have to look at the patient as a whole. Usually this is called as flexion internal rotation deformity, which may be associated with genovalgum. If you look closely, look at the knee and patella, which is facing forward. But if you see this, you can appreciate slight bend in the tibia, as well as the knee and the patella is actually in certain internal rotation. And if you would look this patient from the side, you can appreciate slight flexion of the knee joint as well. Therefore, you have to see the patient as a whole. You have to assess whether it's unilateral or bilateral, plus if it's unilateral, is there any flexion, internal rotation deformity of the tibia as well or not? Because if this problem would not only present with internal rotation as well as flexion deformity, but will also have a leg length discrepancy as well, which we need to sort out during the treatment options as well. and patient can present with this sort of issue, which their patient may have been absolutely normal. If you see the intermallar distance is well below the 8 centimeter mark, it may come up to 4 or 5 6 centimeter, but parents are only worried because according to them what looks likely is that slightly these legs are actually going apart and the patient is having a knock knee problem. So you have to assess it completely. You have to get detailed history, examination, and analyze accordingly, and then you have to understand whether this is it physiological, is it pathological, or whether there is bilateral genu-valgum or not as well. You have to measure intermallar distance, and once you measure it, you have to first label it as a genu-valgum. If it is genu-valgum, then you have to label it whether it's unilateral or bilateral. If it's bilateral, there are different causes of bilateral, and then if it's unilateral, then you have to dig out further whether it's trauma, it's physical damage, what actually has happened to that knee which has resulted in unilateral genu-valgum. Or patient can have a normal posture like this, in which you do not appreciate any actually knock knees. Now coming to the treatment of genu-valgum. If it comes out to be let's say a pathological genu-valgum, and usually if it's, for example, if you see this, can you appreciate if you would calculate the intermallar distance, that would be definitely more than 8 centimeter. Therefore this happens to be a bilateral genu-valgum. Now whatever the cause of bilateral, this could have been a physiological, this could be associated with venous osteodystrophy, or this could be underlying skeletal dysplasias. Then you have to rule out what is the underlying cause, and not only you have to rule out the cause, you have to also treat the bilateral genu-valgum as well. Now if this child comes to you at the age of, let's say, 7, 8, less than 10 years of age, then the main aim of the actually treating this pathological genu-valgum is then to limit its advancement. That, for example, to reduce the further aggravation of genu-valgum, which is more important before the age of 10 years. But if the child comes to you after the 10 years, then there is a different treatment altogether. For example, at this moment the physis is open. What is actually problem is that lateral physis is growing slowly, medial physis is growing more rapidly. As a result, it's actually pushing in such a way that the tibias are going further away because the medial side is growing rapidly as compared to the lateral side. So what you do is you go for physial stapling of the medial side of the tibia. And when we are going for the physial stapling of medial side of the tibia, this is actually we are progressively halting the medial physis to stop its growth. Therefore, actually the valgum reduces, or rather ceases to progress further. Now, if the same child comes to you after 10 years of age, then there are different options, because after 10 years of age, this is another diagram in which we can go for hemiepiphysiodesis. This is also the stapling of the physis. The medial side is actually stopped so that it does not causes the further valgus deformity at the distal femur. Now if the same child usually comes after the 10 years of age, then sometimes the physis has actually already grown, and there is actually the problem is not the physis, because now the physis has already quite matured. The problem is at the bony level. Therefore, once we have genu-valgum after the 10 years of age, we will have to go for some form of osteotomy, that is a bony procedure. Now why this bony procedure is required? Because importantly, what we need to do is we need to deal with the angulation, which is actually hampering the normal growth. And usually when you are dealing with genu-valgum, if it's bilateral, we have to do a corrective osteotomy at the distal femur. And if it's valgus, it's going away, you will have to do some form of called as a closing medial wedge osteotomy at the distal femur, so that the angulation is actually restored back. For example, if you see it over here, now this could be one of the cause in which this was actually genu-varum rather than genu-valgum. If you see appreciated over here, there was a fracture of the distal femur, the physis was damaged, although there was some surgery being done, But this, as the femoral physis was damaged, and you know that normally almost, if you look at the femur, in the proximal femoral physis there is growth of 3 to 4 mm per year. At this level it's 9 to 10 mm per year. Similarly, there's 5 to 6 mm in the proximal tibia and 3 to 4 mm in the distal tibial physis. So the bulk of growth is actually occurring at the knee joint. So if there would be some form of a damage related to medial or lateral physis, this was produce a deformity in form of a genovarum or genovalgum. But if it is genovalgum, which may be unilateral and secondary to trauma, and now the age of the child is more than 10 years of age, and you probably have to go for some form of a corrective osteotomy at the femur.